Okay, so today we're going to talk about calcium, phosphate, and magnesium. Some more electrolytes that are essential for body functions. So looking at calcium, calcium is obtained through the GI tract, so it's what we eat. Dairy products, milk products, cheese, yogurt. 99% of it is stored in the skeletal system. So when we look at calcium and we look at the movement of calcium, most of it is in the skeletal muscle. It is controlled by the parathyroid hormone. So the parathyroid glands that sit behind our thyroid, they are stimulated by low calcium levels, and they cause the movement of calcium out of the bones, and it also causes an increase in GI absorption. When we look at vitamin D, this increases the absorption of calcium through the GI tract. So that's why when patients take calcium tablets, there's a little bit of vitamin D in there. Calcitonin is found in the thyroid, and it increases the calcium deposits in the bone. So when we have a high calcium level, or we've eaten a lot of calcium, it will help store that in the bone. Calcium is essential for nerve impulse transmission, and when we look at this, we're going to be looking at what is it doing to our nerve impulses. It's also for our myocardial contraction, and it's also for bone and tooth formation. So when we look at hypercalcemia, this is a calcium greater than 10.2 milligrams per deciliter. 2/3 of it are caused by hyperparathyroidism. 1/3 of it is caused by a malignancy, either through the bone or through the parathyroid. It's rarely caused by ingestion of too much calcium because only 30% of it is absorbed, and that 30%, that other 70% is typically excreted. When we look at hypercalcemia, some of the causes can be, again, hyperparathyroidism. We can see this in malignancies, our breast cancers, our lung cancers, our bone cancers. We're going to see that. We can also see it in immobilization. So our patients that have had orthopedic surgeries and they're laying in bed, or our patients that have been on a ventilator for a long period of time, we want to start watching that calcium. We can see it with a vitamin D overdose and with our thiazide diuretics. Our clinical manifestations, we're going to see lethargy, slow, weak muscle and nerve responses. We're going to have muscle weakness, a decrease in our reflexes. We're going to have slow reflexes. We're going to have confusion. And then we're also going to see some ventricular dysrhythmias. As I've said before, you don't need to worry about the cardiac dysrhythmias. We'll talk more about those when we get to cardiac. The treatment for hypercalcemia is to get that calcium down. So we want to use either calcitonin, a synthetic calcitonin, to help increase the resorption of calcium to the bones. We also want, if it's due to immobility, we want to start mobilizing our patient. With hypocalcemia, this is a calcium less than 8.6 milligrams per deciliter. This is typically due to incidental removal of the parathyroid, so our patients that have had thyroidectomies. Parathyroids sit right behind the thyroid. They're about the size of the head of a pin, and sometimes they get accidentally removed. We can see with this, low calcium allows sodium to move in, and it helps increase the excitability of those cells. Some of the causes, we can see hypocalcemia with chronic renal failure. We know that calcium is excreted through the kidneys. We can see a hypoparathyroidism. We can see it with vitamin D deficiency. And the latest movement is for us to now start having vitamin D labs drawn to see if, because our patients that are hypocalcemic, is it because of vitamin D deficiencies? We can also see it with alcoholism and diarrhea. And we can also see this with alkalosis. The high pH increases our calcium binding. And when we're measuring hypocalcemia, we're measuring the free calcium. With our clinical manifestations, we're going to have depression, anxiety, and confusion. We're going to see a hyperreflexia, and we can do this by checking our chavostics, which is this picture right here. By tapping on the facial nerve, we can actually cause a muscle spasm in the face. So you can see this picture here, somebody's tapping on the facial nerve, and we have this contraction of the cheek muscles. We can also do a trousseau sign, and a trousseau sign is where we put the blood pressure cuff on, and all of a sudden the hand has like a carpal spasm, and it actually will close up on itself. If it's not treated, hypocalcemia can lead to tetany, which is cramps on crack, and so your patient may complain of severe cramps. Not the light cramps of hypokalemia, but we're talking cramps on crack. These hurt and hurt and hurt, and you can actually see the muscle contracting. They'll start complaining of a numbness and tingling of their extremities and around their mouth. If it's not treated, if hypocalcemia is not treated, eventually it can lead to laryngeal spasms. And in this case, our patient will need a a tracheostomy, because they'll actually, with the laryngeal spasm, you're unable to maintain a airway. When we look at phosphate, phosphate is the primary anion, so it's negatively charged of the intracellular fluid. It is essential for muscle cell contraction. It's also essential for RBC function. Kidneys, again, are our primary site of excretion. So those patients that have renal disease, we're going to see some hyperphosphatemia. When we look at hyperphosphatemia, a lot of it is caused by renal failure. This is a phosphate that is greater than 4.4 milligrams per deciliter. We can see this with some chemotherapy agents and with a hypoparathyroidism. Now, with calcium and phosphate, they have this inverse relationship. So if you have a low calcium, 9 times out of 10, you're going to see a hyperphosphatemia. So we can see this with excess ingestion of calcium. We can see it with hypoparathyroidism. The signs and symptoms are going to be the same as with hypocalcemia. So we're going to see that trousseaus, that chavostics. We're going to have laryngeal spasms. We're going to have tetany. The treatment for this is going to be treat the underlying cause, and it's going to be dietary restriction of phosphates. In our chronic renal failure patients, we give them supplements that they take with the first bite of food that actually binds the phosphate so that it's excreted through the feces. With hypophosphatemia, we see this, it's a phosphate less than 2.4 milligrams per deciliter. We see this in malnutrition. For those patients that have gotten lots of glucose administration, total parenteral nutrition, we see it with that. Alcohol withdrawal. It's so important. If we have a patient, we ask them about their alcohol intake, and we can actually see a hypophosphatemia with that. We can see it with antacids. They're going to bind the phosphate. Some of our clinical manifestations, we're going to see confusion. We may see some coma. We're going to see, again, some cardiac dysrhythmias. And if you think about it, if we're hypophosphatemic, we're going to be hypercalcemic. So we're going to see a lot of that muscle weakness, that lethargy, that confusion associated with a hypercalcemia. So magnesium is another one that we will be talking about. It's the second most abundant cation in the intracellular fluid. It is mostly contained in the bone. It assists with the metabolism of our carbohydrates and proteins. It's absorbed in the GI tract, excreted through the kidneys. So again, kidney failure. When we cover kidneys, you're going to see this more and more. Magnesium, potassium, and calcium all go hand in hand. So if you have a patient that is hypokalemic, so they have a low potassium and been given lots and lots of potassium supplements and the potassium hasn't gone up, ask your physician or your healthcare provider to check the magnesium and the calcium, because those guys are going to be low also. When we look at a hypermagnesemia, this is a magnesium greater than 2.5 milliequivalents per liter. A lot of times it's caused by renal dysfunction. It can also be caused by excessive intake. If we're giving magnesium or in our Malox, our milk of magnesia, especially IV with our patients that have preeclampsia, our clinical manifestations, we're going to see lethargy and drowsiness. Again, we're going to look at decreased deep tendon reflexes. So we want to be assessing what do those deep tendon reflexes look like. In severe cases, we're going to see a respiratory and or a cardiac arrest. So for our patients that have hypomagnesemia and we're giving them lots and lots of magnesium, we want to be assessing what is their heart rate, what is their respiratory rate, because it can, if it's given too much, it can lead to a cardiorespiratory arrest. With hypomagnesemia, this is a magnesium of less than 1.5 milliequivalents per liter. It's most common caused in starving, alcoholism, and fasting. It could be also diarrhea and vomiting, so not intentional starving, but with severe diarrhea and vomiting. We can see it again with malabsorption. We can see it with NG suction, diuretics, and total parenteral nutrition if there's no replacement in it. Our clinical manifestations, we're going to see confusion. We're going to see an increase in our deep tendon reflexes. We're going to have tremors and seizures and some cardiac dysrhythmias. So again, we're not going to be looking at a lot of cardiac dysrhythmias right now, but we can see those. The treatment's going to be to increase our dietary intake, increase in nuts, increase in bananas, oral supplements. Now I will tell you with oral supplements with hypomagnesemia, you want to use caution. I had a patient one time that was admitted that had a magnesium of 1.2, so we gave him oral magnesium tablets. Now magnesium is the same thing that's in milk of magnesia. Patient got magnesium tablets 4 times a day for 2 days. The 3rd day he had diarrhea. Next thing you know, everybody's thinking that he has a C. difficile, and they put him in isolation. It had nothing to do with a C. difficile. He had too much magnesium, which was causing diarrhea. So you want to use caution with that. If we're giving it IV, we want to monitor our patient because, again, like I said, too much, too fast is going to cause cardiorespiratory arrest. And that's all I have to say on that. Have a great day.